Hello, welcome to today's presentation, Managing Gestational Diabetes, a Healthy Pregnancy Journey, presented by Dr. Prasad Katta, endocrinologist with Washington Health Medical Group. Dr. Katta is the medical director of the diabetes program at Washington Health. He graduated in medicine from the University of Gilbura, India. He completed his residency in medicine in Great Britain and obtained the degree of MRCP, Member of Royal College Physicians. He obtained residency in internal medicine at University of Medicine and Dentistry of New Jersey and fellowship in endocrinology and metabolism from Charles R. Drew University. Dr. Katta is board certified in internal medicine and endocrinology. His interests include diabetes, thyroid, and osteoporosis. Please welcome Dr. Katta.
Hello, thank you for giving me this opportunity to give this talk on managing gestational diabetes. The first slide I wanted to say I don't have any disclosures. We'll be talking about, we were going over the overview of gestational diabetes that includes introduction and also the prevalence of gestational diabetes. What are the risk factors of gestational diabetes? How is it diagnosed? There are a couple of different ways to do it, so I'll be talking about that. Treatment of the condition, complications if not managed, and long-term complications for the mother. So coming to the introduction, gestational diabetes is a type of diabetes that develops during pregnancy. It usually appears in the second and trimester, but it can also mothers can get it in the first trimester if they have risk factors. It happens when the body cannot make enough insulin to keep the blood sugars normal. So what happens during pregnancy is some of the hormones which are produced by the placenta called the human placental lactogen, the progesterone and estrogen, they contribute to the insulin resistance. So because of the insulin resistance, this condition affects how your body uses your blood sugars. So it usually goes away after the baby is born, but still needs careful management during the pregnancy. Many women with gestational diabetes have healthy pregnancies and healthy babies with proper care. It's different from having type 1 and type 2 diabetes before pregnancy. Early diagnosis and treatment can make a big difference with respect to both mom and the baby. So this is a diagram, sort of a schematic representation with respect to the different hormones which are produced by the placenta. So here is the estrogen, the progesterone, and also the human placental lactogen. These are the three hormones which increase the insulin resistance. So that again increases the blood sugars in the mother. Prevalence of gestational diabetes, according to the United States Preventive Services Task Force, short form is USPSTF, and usually the prevalence is between 5.8 and 9.2% based on the traditional diagnostic data, but it can vary in different areas based on the race and ethnicity in that area. And in Fremont especially, we do have a lot of pregnant women with gestational diabetes because of our diverse population here in the Fremont area. The risk factors for gestational diabetes include obesity. Women with obesity are 3 to 4 times more likely to develop gestational diabetes. Advanced maternal age greater than 35 years also contributes to the risk. Family history of diabetes, especially in the first degree relatives, mom, dad, brothers and sisters, increases the risk of gestational diabetes. And if the mother has had a previous history of gestational diabetes, that also contributes to the risk. Ethnicity, as I said, can be a risk factor, especially in races like Hispanic, Native American, South or Southeast Asian and Pacific Islander. And also there's a condition called polycystic ovarian syndrome, which is a condition where patients are either pre-diabetic or have insulin resistance. That also increases the risk factor for gestational diabetes. And pre-pregnancy overweight or obesity, as I mentioned earlier. Sedentary lifestyle also can increase the risk. Hypertension, either pre-existing hypertension or gestational hypertension. Gestational hypertension is also known as preeclampsia. That also increases the risk of gestational diabetes. And multi-gravidity, if the mother has twin pregnancy or triplets, that also can increase the risk of gestational diabetes. How is it diagnosed? Most women are screened between 24 and 28 weeks, and sometimes if the risk factors are there, they can be screened earlier. The test used is called the oral glucose tolerance test. The pregnant mother is given a sugary drink, and the blood sugars are tested at different intervals. And if the blood sugar is higher than normal, then the diagnosis is made. Sometimes, as I said, if the risk factors are there, this test is done earlier. That is in the late first trimester, which is in the last part of the 12-13 weeks. Diagnosis helps to protect both mother and the baby from complications, and you'll likely need to repeat the test after the pregnancy, and that is usually recommended to the mother 6 weeks after delivery. So there are two methods of diagnosis. One step method is recommended by the American Diabetes Association or the ADA, and the two-step strategy is recommended by the American College of Obstetricians and Gynecologists, short form ACOG. So the one-step strategy involves taking a glucose load is usually a sugary drink, 75 grams, is given at between 24 to 28 weeks, and the plasma glucose levels are measured at fasting, 1 hour and 2 hours. And the fasting should be less than 92, 1 hour should be less than 180, and the 2 hours should be less than 153. So if one of the following values are met or exceeded, then you have gestational diabetes. This is as per the ADA standards, American Diabetes Association standards. Coming to the ACOG, they have a two-step method, and this involves the initial 50 grams glucose load, and for this the mother doesn't need to be fasting, followed by 100 grams glucose tolerance if the 1 hour plasma glucose on the 50 grams is greater than 130. So first you do the 50 grams, and if your glucose is more than 130, you go to the 100 grams. So with the 100 grams, you measure it at fasting, 1 hour, 2 hours and 3 hours, and the corresponding values are 95 for fasting, 180 for 1 hour, 155 for 2 hours, and 140 for 3 hours. So the American Diabetes Association supports the one-step strategy, and the American College of Obstetrics and Gynecology endorses the two-step. They say this is a better method in reduction of complications like high birth weight, which is also called as macrosomia, and shoulder dystocia is a condition when the baby is coming out of the mother's womb during the labor. The shoulder does not, you have difficulty in delivering the shoulder, so that's why it's called as shoulder dystocia. And with respect to the two-step strategy, it also accounts that the small for gestational age births is less. So this method is easier to implement as the initial screening test does not require fasting. So what's the treatment? Usually the first part of the treatment is lifestyle and monitoring. The first step is often diet and lifestyle changes. You will be more than likely referred to a dietitian and a diabetic educator. You will be meeting them after you see your obstetrician, and they will educate you about a balanced meal, about eating whole grains and lean protein, etc. The recommended dietary recommendations are about 175 grams of glucose, that's about 35% of the 2000 kilocalorie diet, a minimum of 71 grams of protein and 28 grams of fiber. Carbohydrate control is the most important thing, and you should not eat too much at once of carbohydrates, because that will definitely increase your sugars. Physical activity like walking helps to control your blood sugars. especially we want the pregnant mothers to walk about 10 to 15 minutes after meals, for 10 to 15 minutes after meals, so that way they can lower their after meal blood sugars. So again, we want them to check their blood sugars regularly, at least 4 times a day, fasting and also 1 hour after eating. Keep a log of your readings to track patterns and show to your healthcare provider. As I said, you'll be more than likely meeting a dietitian and a diabetic educator, and also stress management and adequate sleep play a very important role, because if they don't sleep well, usually your fasting sugars can be high, and we may have to sort of treat you with medications in those circumstances. So with respect to the blood sugar monitoring during the gestational diabetes, what are the target values? The fasting plasma glucose should be less than 95, the 1 hour after meal less than 140, 2 hours less than 120. So we only want patients to check 4 times a day, which is the fasting and 1 hour after eating. We don't usually recommend 2 hours because majority of the times 1 hour is the important thing, and if the 1 hour sugars are high, then we'll have to look at what we need to do, maybe prescribe insulin, things like that for those meals. You can use CGM or continuous glucose monitoring, are approved by the FDA and also by the ADA for use in pregnancy. I still personally ask patients to check their sugars or at least log their sugars fasting as soon as they get up, and also 1 hour after eating, because as CGM is a continuous glucose monitoring, they may not remember exactly what their sugars were for each meal 1 hour after eating or in the morning when they get up. These are the meters on the continuous glucose monitoring. Both the Freestyle Libre 3 and also the Dexcom is approved by the FDA. And there are many meters. One of them I've shown here, One Touch. There are all so many different meters. Patients can use any meters. Most of them do the job of checking the sugars and keeping track of the blood sugars. Treatment. So coming to medications, if the diet and exercise are not enough, medications may be needed. So these treatments are definitely safe during pregnancy and keep both the mother and the baby healthy. Medications doesn't mean that you have failed in taking care of your pregnancy. It's just a part of the plan. Insulin injections are the most commonly used medication. The first line pharmacological treatment, as recommended by the American Diabetes Association, is insulin, as it does not cross the placenta and it is safe for the fetus and definitely the mother. While oral agents like metformin, which is a very common drug used in type 2 diabetes, and also glyburide, another medication which is used in type 2 diabetes, have been studied, it's not recommended as first line treatment due to concerns about placental transfer to the baby and the long-term safety on the offspring. Your healthcare team will definitely adjust your doses as the pregnancy progresses. As the pregnancy progresses, usually the insulin resistance increases, so more than likely your medications doses has to be adjusted. Regular checkups will monitor the baby's growth and the mother's sugar control. Always follow the treatment plan closely. We want at least 75 to 80% of your blood sugars to be under control. The rest 20%, yes, they can be high, but not like too high. Coming to medications, insulin, long-acting insulin usually taken once a day at night to control the morning sugars. Sometimes you may have to take it twice a day, but the majority of the times once a day should be enough. And short-acting insulin to control the mealtime sugars. I'm not going into details of all the names here because again it differs from like insurance to insurance. There are about 5 or 6 long-acting insulins and at least 5 or 6 short-acting insulins. Any of them do the job in most patients. Oral medications, you can use metformin and or glyburide. Up to 46% of the patients who use oral medications need insulin. So even if the patients are started on oral medications, you definitely have to educate them that they more than likely will need insulin, especially if they develop gestational diabetes in the early part of the pregnancy. It can definitely cross the placenta and also cause low blood sugars in the newborn in the case of glyburide. So possible complications if not managed well: high birth weight macrosomia, as I discussed earlier, can make the delivery harder and can cause shoulder dystocia. When the baby is coming out in a vaginal delivery, the shoulder gets stuck and they may have to use other procedures to deliver the baby. Low blood sugars in the baby after birth. This can happen because the baby in the mother's womb is exposed to high blood sugars, and when the baby comes out, whether in the form of normal delivery or a C-section, the baby can have low blood sugars because the baby still thinks that it's in the mother's womb and starts producing more insulin than it's required. So during these types of situations, we call it neonatal hypoglycemia. So the baby will need to be fed either by putting a tube through the nose or by a drip, like a glucose drip intravenously. Preterm birth or need for cesarean section is also one of the risk factors. Increased risk of preeclampsia, high blood pressure in pregnancy, higher chance of baby developing type 2 diabetes later in life, and mother also has a higher chance of type 2 diabetes in future. I'll talk about this in the end. With proper management, both complications can be prevented. So postpartum care after the delivery, in most cases the blood sugar returns to normal after delivery. As I said earlier part of the talk, you should definitely be tested 6 weeks after the delivery to confirm. A small number of women may continue to have diabetes or pre-diabetes. You should have regular diabetes screenings every 1 to 3 years by the primary care physician. Healthy habits after pregnancy to reduce type 2 diabetes, at least to try and get back to the pre-pregnancy weight, if not even less than that. That should be one of the goals, maybe after the breastfeeding, nursing, and that is, breastfeeding is encouraged as healthy for both mother and the baby. And continue with balanced diet and regular activity, and keep the follow-up appointments with your healthcare provider. Again, some of the lifestyle tips and future prevention: maintain healthy weight before and after pregnancy, eat a balanced portion control diet, exercise at least 30 minutes most days a week, quit smoking and limit alcohol if applicable, manage stress and get good sleep, involve your family in healthy habits, it helps everyone. If planning for future pregnancies, talk to your doctor early. This is very important because sometimes I see patients, they come in for their first pregnancy and then maybe 3 or 4 years later, they may not be diabetic or they may be pre-diabetic, and once they become pregnant, they may develop diabetes, and that should not happen. You should always plan for your future pregnancies, talk to your primary care doctor or your obstetrician. Staying healthy now helps with your baby in the long run. So what are the long-term risks for women who have gestational diabetes? This is as per the American Diabetes Association. Women with a history of gestational diabetes have significant increased risk for developing type 2 diabetes in the future. The lifetime risk is as high as 60%. So if you look at it based on each decade, so there are 10 years after your delivery, your risk is about 20% higher. On the 20 years, it's about 30%, 30 years, 40%, and 40 years, 50%, and again, 50 years, if someone is pregnant at 30 years, when they're 8 years, it's almost 60% chance they will develop diabetes. And if you have any questions, I'll be more than happy to answer.
Thank you, Dr. Katta. We do have a couple of questions. The first question is, can a healthy mother with no pre-risk factors still develop gestational diabetes?
Yes, they can. Means again, the risk factors, even though it's not, those are the only risk factors. Genetically also they can be predisposed. Definitely, yes, that can happen. But in majority of the cases who we see, they have some risk factors or the other. Yes.
Okay, and our last question is, after a mother with gestational diabetes gives birth, will her blood sugar go back to normal if she was not diabetic before?
Yes, majority of the time I would say, again, this is my personal experience, I don't know exactly the percentage, I would say 98-99% of the time it goes back to normal. We definitely encourage the pregnant mothers to get their 6-week glucose tolerance test. That is very important. At least then they'll come to know whether it's normal or they're in the pre-diabetic range, or if they're in the diabetic range, at least they can seek help. But it's very important to get the 6-week glucose tolerance test after delivery.
Okay, thank you. This does conclude our program, and thank you, Dr. Katta, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.